Hello, everybody, and thank you for participating today in the webinar. Um, this is a continuation of best practices for opiate use disorder treatment. And I'd like to thank Dr. Chris Jones, the director at Northwest AHEC at the Wake Forest School of Medicine, for allowing me to participate again. And if you need to reach out to him or myself, my email is right there. If you have any questions at the end concerning this webinar or any other follow-up. So today is opiate use disorder, the integrated treatment approach, as well as a community coalition model. And we're going to be talking about evidence-based treatment today. And I have no conflicts of interest to disclose. I will give you a disclosure that I'm CEO and clinical director of integrated care of Greater Hickory, and we apply this integrated model here at our own program, a community behavioral health agency, between Catawba and Lincoln County. I will also tell you that I'm the chairperson of Project Lazarus of Catawba County. It is a community coalition. My doctorate is in health science, applied health science research. My work has been with healthcare providers with substance use disorder. And my only other disclosure is I'm a peer reviewer at the International Journal of Medicine. So the objectives today, we want to understand the current status of the opioid crisis in the U.S., so we'll briefly go over some statistics. We want to describe the evidence, principles, and components of the integrated treatment model. And then we want to move over and summarize key components of a community coalition model, and we'll use the Project Lazarus program as an example. And so why are you here today? Healthcare providers and others that deliver services to this population, we need to know about evidence-based models of treatment and prevention, particularly in the middle of this crisis. And similarly, we want to be able to apply these skills in our own setting or be able to refer people suffering from this disorder to those who can deliver these services. So let's describe some of the statistics briefly, and this is why you're here today, is that for more than 2 decades, the United States has been experiencing a public health crisis related to the abuse of heroin and other powerful narcotic medications. And the opiate epidemic is devastating our communities through loss of employment, worsening physical health, increasing rates of crime, and overdose deaths. And specifically about death, the United States has now reached 115 overdose deaths daily due to heroin and these powerful opiate medications. Last year, North Carolina had a greater than 20% increase. And while some states have had a decrease due to some of these new evidence-based approaches, North Carolina has yet to see an improvement. So from 1999 to 2016, we had 630,000 deaths due to drugs of any kind, with 350,000 of those related to opioids. In 2017, yet again for the country, the numbers rose to 72,000 deaths. And it is anticipated that in the next 10 years, we should see 650,000 deaths, which is greater than all that we've already seen. But these are going to be related just to opiates. That's how exponentially this problem is growing. So what can we do? Are we treating only part of the problem? Researchers, lawmakers, and providers agree that it is crucial for an evidence-based integrated approach for the treatment of opiate use disorder in our country to end the crisis. So the research has demonstrated the effectiveness, and this is the only way that we're going to be able to appropriately treat this problem and turn the tide. So we look at the integrated delivery model, and we know this model has been around for quite some time. It is a biopsychosocial model. You can take any disease such as diabetes, and you know you need the medical component, you need a proper testing, you need a proper medication, and you want to be monitoring and following those laboratory results. But similarly, you want to be able to look at the social influences of the disease and allow for social inputs in treatment planning. So that might be for the diabetic patient, the ability to pay for the medication, properly use the medication, an ADA diet, being able to get transportation to the right grocery store that might have appropriate, healthy foods. And then even psychologically, When we start to look at persons in the medical environment, dietitians and nursing have been able to work with people for the behavioral health change, which would mean, well, I know I need a diet. I might buy the food. Am I going to eat it? I know I need to get off the couch, but what's the motivation to get off the couch? And if I have some underlying psychological problems, is that driving my eating or other bad behavior as a coping strategy? And so while we use this in treatment in medical conditions, we can also look at the opiate use disorder for this integrated approach. The integrated treatment approach for opiate use disorder is essential for optimizing the initiative to expand access to care, which means simply there are people out there that need this care and we need to reach them. It improves treatment and treatment outcomes. So we know that when you look at all the inputs that I described, you're going to get better outcomes. And that makes perfect sense. It's just how do we deliver that care? And then also reducing the incidence of certain co-occurring conditions. So in the course of treatment, you know that you might improve some of these other inputs, such as homelessness and unemployment, are consequences of the disease. And so if you do not treat these co-occurring disorders, you're not going to get the treatment outcomes for your patient. The integrated treatment approach may also be offered within various treatment settings. So while we discussed today the primary care setting and even the specialized opioid treatment program like my own, we might look at HIV clinics and other community-based programs. And that's the second part of our talk today, would be those community-based coalitions. Treatment outcomes. A multitude of factors affect health status. And we know this. Education, the physical environment, culture, behavior, genetics, finances. There are so many inputs to determining our health status. Similarly, when creating treatment plans, we have to look at all of those inputs so that we can get the treatment outcomes that we need. This is particularly true with chronic disease such as opiate use disorder. And we've seen some of these initiatives in our country surrounding patient-centered medical homes, accountable care organizations, and even with health records, which allow for easy exchange of information between providers for the same patient. In North Carolina, the need for an integrated approach is so important that laws have now been created through the Department of Health and Human Services assistance that allow that medication providers for buprenorphine must establish contact with providers of counseling and care management. And so what that says is it's not only good medicine and it's not only ethical medicine, you have to do it because it's the law. And we see that some providers may not be doing that, and we need to work with them and encourage them to create treatment plans that include all of these inputs. What are the different inputs that we can look at for our treatment planning? And we described some of them on an earlier webinar, but I'll briefly go over these. Behavioral interventions, which are counseling and evidence-based counseling models, such as CBT, 12-step facilitation, and motivational enhanced treatments. Medication-assisted treatment, such as Suboxone and Vivitrol. We want to match the medication to the right individual where they are in treatment. Physical medicine, so including the treatment of diabetes, hepatitis, and other conditions. Psychiatric, schizophrenia, bipolar, other types of psychiatric disorders, and when treated with substance use disorder, you get much better outcomes. You also want to include care management for housing, employment, and education. And then other social interventions. What kind of social inputs can you use, such as peer support and the mutual self-help communities, as part of your treatment plan? And with the opiate use disorder, so this is much more than just maintaining abstinence. This is whole person care. The principles for an integrated approach when treating the opiate use disorder patient. We have to have an environment that's stigma-free, judgment-free, that we know it's a medical condition. And even though some of the symptomatology is challenging, stigma-free. Strength-based, lifting and enhancing the person's life. We don't always see this sometimes in the treatment of these persons prior to coming into recovery, but this is where we need to focus. Person-centered. While we have all these experts at the table for an interdisciplinary team, the person who guides treatment planning has got to still be the individual suffering from this condition. Trauma-informed. Many come to us with childhood trauma prior to use, and then sometimes because of the environments and the situations in active addiction, there's more trauma. And so certain counseling is trauma-informed, and we need to use that form of counseling alongside of our evidence-based substance use disorder counseling. Community-based. The environments where the people live need to be a focus if you're going to enhance recovery. And so this is sometimes lacking with in many of our practices, but community-based has got to be the principle that guides treatment planning. Peer support, that shared experience, that one-on-one help as we guide treatment. Outcome-based, is what we're doing working? And if not, we need to reevaluate and do some more planning for this individual. And obviously, culturally competent. Meet this person where they are. So treatment goals. Some of these features here are going to be shared very often when it comes to goals, planning, diagnosis, assessments, and outcomes. Many different providers are going to be looking at different outcomes, different assessments, different diagnoses, different planning. And so what we need to do when we come together as an interdisciplinary team for this whole person care planning, we need to make sure that these are shared. Just because the A1C is down but the person is actively still using, one person thinks that they're meeting their treatment goals and the other one says no, they're not. We need to have all of these goals on the same treatment plan. Thank you. When we look at biopsychosocial, let's look at the first dynamic of the treatment model, which is biological. We've talked extensively about medication-assisted treatment as an important component of the medical dynamic. But we also need to look at the co-occurring physical disorders, laboratory testing. Is it occurring? Who's paying for it? If it's uninsured, who's interpreting it? Very often these laboratory tests are misinterpreted. Pharmacological services. Is the medication appropriate? And can the patient afford it? Is it being diverted? Is it being taken appropriately? And we'll end with the ASAM levels of care. So when we look at people, placing them medically, it may be severe where there's opiates along with alcohol and Xanax, and they may need medical detox. Or maybe maybe you can induce onto the medication, the buprenorphine, in an outpatient setting. Or maybe it's very early on and medication is not absolutely necessary, and you might have basic counseling services outpatient with medical supervision, no medication prescribed. And so these ASAM levels not only match medical interventions, but they also match the psychological intervention. So we'll start with the ASAM levels. We'll look again at evidence-based counseling that we know has worked. Other behavioral interventions for the co-occurring psychiatric and other behavioral disorders such as clinical depression and clinical anxiety. If you're treating only substance use disorder and you're not treating the trauma or the schizophrenia, you're not going to get treatment outcomes that are going to be what you want. You're also not treating the entire person. We want to look at, as part of the psychological, the need for peer support services. North Carolina now has a certification program, and we can even bill for these services within treatment settings. The shared experience is very important. These individuals are able to bring these patients in recovery to their AA or NA meetings, to court appointments, to employment opportunities or educational opportunities. And so when we look at the psychological, we want to make sure that this is also available to the patient in recovery. And these guiding principles of a recovery-oriented system of care. There are some principles and features that we're describing right now that tie into that, and also the interventions also tie into that. And we move over again. So there's an intersection between all of these, and so we're going to start with the mutual help communities that we talked about briefly in psychological. Education, supportive housing, employment, transportation. When you look at an integrated treatment model, the treatment provider should be able to engage the person seeking help in all of these different opportunities. So these inputs are going to make huge difference when we're looking at the treatment outcomes. Again, when we move from psychological interventions to social interventions, the peer support straddles both of those, if you will. And so when you look at all these together in a treatment plan, biopsychosocial, this is what we need to look at. These are the providers on your interdisciplinary team. We addressed all of these providers and their specialties and how they offer help within the opiate use disorder treatment planning team. And so I want to look at them briefly again. The counseling, the medical, and of course the assistance of the toxicologist and the pharmacist. We want to end here with the spiritual component. Now, we are not religious leaders generally in the healthcare environment. Spirituality is very person-centered and comes from that individual, but we want to facilitate that. While many people at that interdisciplinary team are going to be looking at the biopsychosocial inputs, we need to understand very often that person in recovery transitioning from the old life where the ravages of drugs and alcohol sometimes strip away meaning and purpose, they are starting to find meaning, purpose again. And so we want to facilitate that and encourage that, and it is absolutely a necessary part for those people with a faith tradition, those people who call themselves non-denominational spiritual, atheist, agnostic, all sorts of persons want to find meaning and purpose in their life in a very unique, individualized way, and we want to support and enhance this and give them an opportunity to share this in the treatment setting. Recently, I spoke on a governor's panel and tried to find a slide that represented the model for an integrated approach for the treatment of opiate use disorder. Reached out to American Society of Addiction Medicine, reached out to International Doctors in AA, which I'm a part of, and could not find anything. So I've created this one, and I created it for that talk, that panel. And so we have covered all of these today. And if you need the copy of this slide, email me or Dr. Jones at Northwest AHEC. And you'll see, again, this interlapping of the biopsychosocial in the middle there, and then the central spiritual component, because this is very person-centered, so you want to imagine that the person is right there in the center of all of this. You want to always keep in mind the principles and the features of integrated care, as well as treating a person with opiate use disorder. We'll move on now to the Community Coalition. The Community Coalition is an evidence-based model where we improve outcomes for communities with regard to opiate use disorder and other substance use disorders. The first slide I have is people. When you're looking at coalitions, there need to be people of different sectors motivated to help. And so with a shared goal. And so law enforcement, EMS, Department of Social Services, providers of services in the community, religious leaders, educators, all coming together with a shared goal, shared plan. And so you see where when you're doing the treatment planning for your individual in an integrated care model, it's very similar here as well. This kind of shared goal and shared planning. Project Lazarus started in 2007. This is the model that has been tried and researched and tested subsequently. It started with here in Wilkes County, not far from where I am in Hickory. And so many people were dying from opiates, and that they knew they needed to do something drastically immediately. And this was the first use that we know of publicly where the community got together and said, we have to get rescue Narcan out in the community. And so that's where the name Lazarus comes from, rising from the dead. When a person is injected with the rescue Narcan, they rise right up. They're near death, and they rise right up. That reverses the effects of the heroin or other powerful opiate. Subsequent to the effectiveness and the success of using rescue Narcan in Wilkes County, those individuals got together and created more interventions that would work. Subsequently, with great leadership, it's now in 35 different states. It's a very complete model for the community coalition, and includes various sectors with various professionals working together. So this is the model that we have that has been researched and tested, and the research is available at projectlazarus.org. I want to show you each one of these sectors also ties to very specific interventions that have been studied. So interventions that are evidence-based, researched, and proven. Provider education, hospital and emergency departments, diversion control, pain management support, pain patient support, harm reduction, addiction treatment, which we covered earlier, community education and prevention. The components of this model are clear. There's community activation and coalition building, as I said, between various sectors, various professionals, and the community members. Monitoring and surveillance of data is what we're doing working. Why and why not? One of the core components of this, specifically with opiate use disorder and other drugs, is prevention of overdose, use of rescue medications in the community for reversing overdoses, and also evaluating the project components. The first spoke was provider education. This webinar is an example of provider education. So these are principal efforts of educating primary care providers on appropriate management of chronic pain through safe opioid prescribing, and also early detection of substance use disorders. And so that's been a very big part of Project Lazarus in this community. It's been a very big part of Project Lazarus in the 35 different states that it's active now. Although you may be from another county that has a coalition, Project Lazarus might have been very influential of some startup funding and also some guidance. They're not all named Project Lazarus. So Northwest AHEC is a great, like I said, a great example of provider education. And these are some opportunities that from Project Lazarus that I've had, educating providers on the tools that are available for diagnosis, treatment, referral. So SBIRT you know of, or you should. It's a screening, brief, intervention, referral tools, and these are some of our screening tools. Also, Project Lazarus has pushed the opiate risk tool and high risk criteria tool, and these are tools that are helping providers treat with pain management and also help with early detection of a possible problem. So it can guide a lot of treatment planning. But these tools are often provided. We provide education on these tools in various settings. I want to talk about community awareness, reaching out to lawmakers to help when we talk about influencing funding, such as U.S. congressmen and women, also governors, and when it comes to laws like the STOP Act that guide providers and how they practice. And it also affects community awareness as persons in the community will see these very visible lawmakers and others and understand the importance of participation and the need for change and the way we're doing things. The North Carolina Controlled Substance Reporting System, as we said, has been around and now it's part of law. And this is that spoke that we talk about with diversion, to reduce diversion. Years ago, we would talk about using multiple providers, and we would often call it doctor shopping, that some people may know of. But this is an individual using multiple providers for multiple prescriptions and multiple pharmacies. And so there are now some tools, evidence-based tools, such as using this reporting system that have made it very helpful for reducing diversion. Um, uh, Integrated models of care, which include pill counts or prescription lock-ins for one pharmacy, one doctor, have also been helpful. But all of these evidence-based tools help with diversion and allowing a community coalition to get the information out there, and also influence laws that lawmakers that create laws that enhance these tools, making them mandatory for providers, has been shown to have positive effect. So again, that's what the tool looks like when it comes to a controlled reporting system in North Carolina. Another tool that we are now using in our community coalitions is getting these lock boxes out, and even these little pill bottles, these locked pill bottles. We at Project Lazarus and other community coalitions are giving these away for free, particularly people who are on chronic pain medicine or people who are in treatment who use Suboxone and other drugs like Suboxone, to lock them up. Many times adolescents will explore and use some of these medications experimentally, and we're seeing that more and more in our communities today. I love this poster that we're getting out there in primary care settings and other treatment settings, but it says, she gets her hair from her mom, her eyes from her dad, and her drugs from her grandma's purse. And so none of us think that this is happening within our family. So getting these kind of posters out there to increase awareness has been very important. Another way of decreasing diversion and reducing overdoses is prescription take-back. Now we can do prescription take-back with these take-back events. As you can see in the little picture there, tons and tons of medications have been brought back from events, but also permanent lock boxes have been very effective, probably more effective in our county than the take-back events. In safe environments such as law enforcement offices, no questions asked. People walk into our police departments and sheriff's office, and in very secure containers drop the medications off. Many unused medications sit up in medicine cabinets, and either they are taken from somebody in active addiction within the family, maybe through robbery, or through, like we said, experimentation of from young adolescents or children. Let's look at some specific harm reduction approaches. That was another one of the very important spokes on our model. Rescue Narcan, as I said, was how we got Project Lazarus started in Wilkes County and then spread throughout North Carolina and now in 35 different states. But it's just one of those harm reduction methods. But integrated care treatment facilities are giving these out to families where there's active addiction. Similarly, primary care settings are now identifying high-risk environments in the patient's home life and saying, why don't you take one of these just in case somebody in your family who's actively using may overdose. So they can obviously inject and call 911 and get that person to safety. And then there's a real opportunity there to talk about bringing that person into a treatment program. Another one of these evidence-based interventions are safe needle exchanges. These were very controversial for years, but they have been proven to work. They're much less controversial now. We're not always able to get persons into treatment today. But some of the research has demonstrated that you're 5 times more likely to enter treatment if you have participated in a safe needle exchange. Also, healthcare costs and that person's own healthcare status, safe needle exchanges, clean needles, are going to reduce the incidence of HIV and hepatitis across the board, and other diseases such as bacterial infections that lead to cardiorespiratory depression and death. And so we know this endocarditis is a big risk for this population. And so, but like we said with the rescue Narcan, this is an opportunity to talk about treatment. And those persons doing this really good work are able to do that and bring people into treatment. A new evidence-based treatment or intervention that is being used as harm reduction are fentanyl test strips. They're being used throughout the country. Much of the heroin now is laced with fentanyl. A large quantity of fentanyl to an unsuspecting user will kill them. And so while we cannot get everyone to stop using heroin and other opiates today, if they know it's fentanyl, they'll use more judiciously or maybe not use at all. And so that's something that we want to look at. But these are all harm reduction, and it's a very important spoke on our community coalition wheel. We want to circle with some more community awareness interventions, getting the population out there knowledgeable, talking about prevention, the interventions that are there, encouraging persons of the community to come work with us on. This is one that we did in Catawba County, and we brought lawmakers in. And I think when you brought lawmakers in, as well as providing some really good food from sponsors, making it an enjoyable question-answer environment, people were very receptive to this, had answers to some questions that were burning with them, and hopefully dispelled some of the misinformation. Making yourself available with the community coalition at public events. This was an Oktoberfest on the left, and then on the right, it was a recovery rally. These are opportunities to talk about these interventions, talk about the disease of addiction in the medical model, not the moral failing, why these interventions work, what resources are available in the community. Many people would come up to us and say, hey, I got this person in my life that's doing this, and really we don't know where to go. And so these are really good opportunities to increase awareness and bring people, hopefully from the community, to come work with you in the coalition. Churches and civic organizations are another opportunity to talk about substance use disorder, the opiate crisis, evidence-based interventions at work. And so, and now you can kind of see where it's so important to have a lot of people participate, because there's so many different opportunities to do this work and make improvements in our community with respect to this crisis. This is prevention and education as well as awareness. So two spokes there. These are poster competitions that we put on through multi-county coalitions. The students were from middle school and high school, and they were able to create some really good posters about prevention and the disease, and there were prizes that were awarded, and we do that yearly. We talked about hospitals and emergency departments and EMS. You'll see that people who are rescued from overdose are brought to these hospitals to stabilize. Now we need referrals. Now we need stigma-free environments, non-judgmental environments, appropriate information and referrals, and with a warm handoff, not a piece of paper, call this, but real warm handoff. And now many of these rescue programs are allowing somebody from the treatment provider to present at the ER or even at the site of the overdose and start to talk immediately about, let's get you some treatment. Also, a lot of narcotics are coming out of our emergency departments. Many people who have run out of medications have looked into the ERs as a source of opiates. And so, again, talking about the policies and referrals that are available from our ERs to treatment settings. Project Lazarus has been very influential on creating and disseminating information about LEAD, law enforcement assisted diversion. Again, this is where different sectors of the community are working together on the same problem. You have arrest for possession of a drug, rather than arresting them and sending them to jail and then further decreasing their employment opportunities, decreasing their ability to earn an income, take care of their family, worsening the condition of the individual. This is an opportunity where law enforcement can work with treatment providers, and rather than taking them to jail, kind of offer some incentive to participate with the program. And these programs may be as long as 12 months or so that they can avoid the criminal conviction. And this is where we had started today with looking at evidence-based models of care with treatment. But as we said earlier, treatment is only one spoke of that wheel. But if you're going to spend money on treatment, make sure that it's an evidence-based treatment and an integrated approach that gives you the very best treatment outcomes. So treatment providers working with all the other ones on this coalition to participate with improving our communities. So there are references today for the slides. Again, if you have any questions, please reach out to Dr. Jones at Northwest AHEC or reach out to myself at Integrated Care with my email, and I'll be glad to send you a copy of these slides or give you any other information about either the integrated approach of care or the community coalition. So possibly you want to take some of these skills back to your own clinical setting, or you want to work with or establish your own community coalition in your own region. So thank you for listening today, and I hope you enjoyed the lecture.